Well, thank you. Enjoy your lunch. Usually I'm talking about the thoracoabdominal aorta, but this afternoon we're going to be talking about the other end of the aorta, the proximal portion of the aortic root, and specifically about aortic valve sparing, which we'll explain here in a minute. In order to really understand all this, and I'm sure you're familiar with this from your studies, but it's just really important to know the anatomy. Without the three-dimensional and actually the four-dimensional anatomy of the heart and the root, it's really hard to put all this together, but we'll try to simplify some of this. I think it's helpful to remember that the valve and the annulus of the valve is not it's not really just in the aorta. Part of it's actually down into the ventricle, and not infrequently when we're operating on the aortic valve, we'll see a ventricularization of the sinus portion, usually underneath the right coronary artery. So the valve is what really bridges the ventricle in the aorta. Now we have a lot of tools in the chest with regards to replacing the aortic root. Some are listed here, and I'm going to add a couple here in a second. The composite valve grafts, the so-called Bentel operation, a bioroot, which is a porcine root. It's the Medtronic freestyle root. Then we can take a tissue root and sew it into the end of a Dacron graft and create our own composite valve tissue graft. Then there's homografts, and of course valve sparing, which is what we're going to be talking about, as well as the Ross operation, where we take a pulmonary autograft and put it on the aortic side, and then take a pulmonary homograft and put it back into the pulmonary side. So we're going to look at just a little bit of data from the Society for Thoracic Surgeons Adult Cardiac Surgery database. It's really an amazing database. It's really been extremely well adapted in the United States. I remember being part of the STS when this first came about. The Society for Thoracic Surgeons actually almost went bankrupt trying to get this thing off the ground. And now it's really a cash cow for the society. But it's got over 8.3 million operations from over 1,000 institutions, and over 97% of the hospitals in the United States that perform cardiac surgery participate in it, and there's over 3,000 active surgeons who've contributed to it. So this is a relatively recent report that kind of gives us kind of a landscape of what's going on around the aortic valve in the root. And I'm just throwing this in here because we do so many TAVR operations. And although we used to do a fair amount of root enlargements and annular enlargements, Nick's operations, Manoogian's, now Bo Yang's, et cetera, since 2020, you can see how root enlargements have really skyrocketed in order to accommodate the TAVR operations later. There's been a resurrection of the Ross operation, which I mentioned earlier here over the last 5 years. And you can see that it's really rivals aortic valve repair. And theoretically, they don't compete with each other much, but there is a little bit of a overlap. Aortic valve repair here includes, of course, aortic valve sparing. This is looking at all the ascending aorta, which you can see here is between about 25,000 a year back in 2023. There's not a lot of data on 24 and 25 yet. You can see that the roots have been slowly increasing, and dissection has pretty much been stable. Now this is root replacement, composite, and valve sparing put together, but most patients still get a composite, so-called Bentel operation as opposed to valve sparing. Although in the last few years, there has been an increase back in valve sparing. I don't really understand while valve sparing took a dip there from 2019 to 2020 to 21. COVID may have had a little bit to do that, but some of that decrease actually precedes COVID. So anybody who knows me and has listened to some of my blabbering before knows that I like to talk a little bit about history. So let's just talk a little bit about how we got here. The first real attempts to replace the aortic valve was by Hufnagel, and this is a lucite ball in a lucite tube, which then they put was designed primarily for aortic valvular insufficiency, and most of these were put into the descending thoracic aorta. in reading about this, the combination of those two materials, these things were really loud, and they ultimately changed the ball before this was kind of relegated to history from lucite to something a little less noisy. But these go back to 1952. Before that, there really wasn't much of anything. The first artificial valve in the anatomic location of the aortic valve below the coronary arteries, probably from Dwight Harkin back in 1960. So you can see a fair amount of time passed, and he was at the Brigham in Boston. There was again, a lucite ball. Patient lived 20 years, the first one that they did, in a metal cage that could be sutured in a subcoronary position. But although he wasn't the first, Al Starr really took off with this and got with a gentleman by the name of Edwards and developed these valves that you see here. And the several iterations of this were extremely good, and they lasted a long time. We've taken out some of these just in the last 10 years that have been put in decades and decades before, where the valve was still okay, but they developed a root aneurysm and had to have things managed in that way. So we're talking about the root, we're talking about more than just the valve. So the first successful resection of the ascending aorta was done with a homograft, reported in JAMA in 1956. And it was a combination of efforts by Dr. Cooley and DeBakey back when they were working together. I think it's sort of interesting to remember, but before they split after the April 1969 problem, they had worked together for 18 years. It wasn't like they didn't know each other pretty well. And they used the DeWall-Lillihei pump oxygenator for that first case and replaced the ascending aorta with a homograft. Another effort which was important, particularly in aortic dissection, was Myron Wheat out of Florida. And he replaced in more or less the entire ascending aorta by placing like kind of keyholes around the coronary arteries and scalloping the graft so he's got the valve replaced and the scallop graft down towards the annulus. And it was very popular for type A aortic dissections after his report. So a lot of these cases were done in patients with connective tissue disorder, Marfan, of course, and we'll have you replace the valve and you place the ascending aorta. The root's going to continue to expand over time, so we needed a little bit different solution for that. And Hugh Bentel and Tony DeBono reported this paper in Chest. And it's interesting that we still call it the Bentel operation. This is not a landmark operation from a volume standpoint. It's 2 pages. It's a couple of diagrams. It's got a photograph in there. It's just a case report, but it really changed things. Dr. Crawford once told me that Bentel had actually seen somebody else do this and went and reported it real quick in Chest because Chest had a very rapid turnover from submission to publication. Anyway, Dr. Crawford was absolutely convinced of that, but it really changed the landscape. Now we could replace the valve, the root, and the ascending aorta completely. Oh, this particular manuscript, this case report, only has one reference. The reference is actually a paper by Dr. Cooley. So then comes along Sir Maggie Yacoub, and he takes a modification of kind of what Myron Wheat did, but he takes a spin on it. Instead of making keyholes for the coronary arteries, he scallops down each of the sinuses and makes a hole and then reattaches the coronary directly. And this has been referred to as remodeling, and he popularized this in 1979. Somewhere about 1990, I was talking about him, and we were beginning to look at a lot of more mitral valve repairs, and he said, why not? We should be able to spare both the aortic valve as well as the mitral valve. So a spinoff on this was Dr. Tyrone David from Toronto. He and Fendel reported this in 1992. They had 10 patients, 5 of them had Marfan syndrome. And instead of scalloping down around the valve, what they did was is they put a tubular graft down and brought the valve and the leaflet structure up inside the graft. And this is the David operation now. There's various iterations of the David operation, and it's really become a very standard aortic valve sparing operation. He has stressed, and we'll talk about this in a minute, but he stressed the importance actually of using a straight tube graft for these reconstructions. So let's jump forward now, and these are some of the major guidelines. The Borger for the European, Cerny for the European, and Isselbacher in JACC for the American Heart, STS, et cetera. And basically, they all say the same thing. Borger's a little stronger, but valve sparing is recommended in young patients, aortic root dilatation. You have to have valve cusps, which are acceptable. And if it's in an experienced center, it's a class 1 recommendation. The level of evidence is not bad. It's B. The others, Cerny and Isselbacher, basically say the same thing. Tyrone David didn't just go from Bentel operation to the David operation overnight in one jump. And in his writing talks about newer operative procedures are usually the result of a stepwise logical progression of previously known operations, but stresses the importance of knowing anatomy about the aortic root, the annulus, the aortic cusps, and the sinotubular junction you can see here in this diagram. The virtual ring of the valve actually sits down inside the left ventricular outflow tract. So what did he do? He had a patient that had a normal valve cusps. The right and left coronary sinuses were fine, but the non-coronary sinus was aneurysmal. He was replacing the ascending aorta, so he just created a large scallop and replaced the non-coronary artery sinus, and the diagram you can see there is on the left. And then he ran into another one that had the left and then the right, and he had another one that had the left, the right, and the non-coronary. So he went stepwise from 1, 2, and finally 3 scallops, very similar to what Magi Yakub was doing. But then he got the idea of pulling the graft up inside the tube, and the valve up inside the tube. And then there was some pressure on him. The way he describes it is that there was this idea that the sinuses are important. So then he began to do what's sometimes referred to as something similar to the Stanford modification, where the graft was pleated to create sinuses where the coronary arteries come off, as well as a non-coronary artery. And in the scalloped graft, as you can see down there on the lower right, many of these patients later would come back with the annulus dilating, and then he moved towards reinforcing the annulus with an exterior strip of felt or Dacron to prevent that. We can talk about that a little bit more in a minute. So he stresses that the normal aortic valve is contained in a cylindrical structure with the sinuses coming off of that cylinder, but the basic construct is a cylinder, so that the trigon, the area between the commissures, is actually straight up and down, and then the sinuses bulge out from that. And Dr. David has been a very strong advocate of this straight tube graft throughout his career. So I'm going to add a couple of other additional options just to cover for a minute. The others, Tom Martin trained with us years ago, and he's now in Gainesville, Florida. And he came up with this idea of a Florida sleeve procedure, which is kind of a modification of the Myron Weed operation plus the inclusion technique, which is the standard valve sparing operation for the David. In other words, mobilize the aortic root, bring it up in a graft, but instead of reattaching the coronary arteries as buttons, make little keyholes, and he thinks makes the operation a little easier. And he's published some really good results on this. Not a huge number of patients, but the mortality rate is good and the stroke rate is low. And the survival out to 8 years and freedom from reoperation, as you can see here, is in the 95 to 96%. The other option that's out there, it's not available in the United States, is called the Personalized External Aortic Root Support, or PAERS operation, and it's an exovasc graft. These guys started out primarily in England. There was an engineer with Marfan syndrome who had a dilated root, and he didn't want to have traditional operation. His root wasn't big enough yet to get fixed, but it was growing. So he came up with this microporous textile mesh that's based on CT scan reconstruction with 3D modeling, and then this mesh is built bespoke for the specific patient around that 3D reconstruction, and then this can be wrapped around the aorta you can do it all off pump. These are in a number of countries around the world. Most of them have been done in England. They sort of suggest that they're patients who are at high risk for dissection. In other words, somebody has a family history, rapid enlargement, a woman who wants to become pregnant, or if it's enlarging. And the people who've really pushed this are the two names you can see here. The first one's John Pepper, and then the last name, Dr. Tom, Mr. Tom Treasure. So they've had some reports. There's about 1,000 of these have gone in. The results are actually pretty good here. You can see that the age here is a little bit younger than what we see for our valve sparing operations at an average age of 33, and the diameters are smaller, as it should be. For this, to be doing these on young patients at smaller sizes, the risk should be very, very low, and the stroke rate death is indeed low. This is a propensity match grouping. It's mostly male. The diameter is about the same. Marfan syndrome makes up most of these patients in these series. The stroke rate is very, very low, and the mortality rate is essentially zero. The Marfan Foundation actually has an opinion on this. They say that it's not available in the US, but currently in Europe, Britain, Australia, Singapore, and New Zealand make up the majority of them. It really should be for genetic conditions, Marfan syndrome and Loeys-Dietz, in women with an ascending aortic or root aneurysms who are planning a pregnancy, and provided the aortic valve cusps are normal and that they function uneventfully. Also, going back in history, I think it's kind of interesting that Francis Robicek came up with an operation that's kind of somewhere between the Yakub operation, the Florida sleeve operation, the Myron Weed operation, and designed a graft that had, instead of having a straight tube, it was actually separate scallops that were attached to enlarge. And it was this Robicek compliant aortic sinus graft. And the idea here is he felt it was very important that for the proper functioning of the aortic root in the sinus segment was to maintain the elasticity so that it could expand and contract and have that motion. And there's some justification of that, dampening some of the energy force as it leaves the left ventricle. And he actually patented this graft, as you can see here, from a number of years ago. And then actually he had another graft that he patented even before that, which he did something very similar to the sinus valsalva graft that we use now. So if you go back and look at these things, somebody probably already thought of what you want to do before. And many of us really thought that the sinuses are there for a purpose. This so-called Leonardo da Vinci concept of the flow inside the sinuses helping the valve cusps to open and then close. The valve just in the native situation doesn't just open, close, open, close. The sinotubular junction actually is displaced distally from the elasticity of the sinus segment, so it's moved radially distally, which helps pull the cusps up. The sinotubular junction expands and pulls the cusp out. So it's not just a pressure difference; it's actually radiologic changing the shape in such a way as to assist in having the valve leaflets open. And Rogério de Paulus in Rome, well, we need to create this, and so he came up with this Valsalva graft, which most people are familiar with, and he's had some modifications early on as he was putting this thing together. But basically, it's a tube where the sinus segment is really kind of a reversal of the direction of the crimping, and it allows it to expand. He's shown in some very elegant studies that this type of reimplantation for the valve sparing allows an anatomic reconstruction of the root and the leaflet motion to be similar to normal subjects, so he defends it quite readily. Gaudino and others have done 4D MRI flows comparing straight grafts and Valsalva grafts. And quite frankly, the bottom line is both of them actually can work very, very well. And Rogério has published some really, really good results. You can see here in survival out to 150 months. So well more than a decade is excellent. And freedom from aortic regurgitation using the Valsalva graft is also excellent out to a fairly long period of time. The freedom from aortic regurgitation of greater than 2+ is 94% at 5 years and 87% at 13 years. And he's got some 20-year experience with this Valsalva graft that he came up with, and the freedom from recurrent regurgitation greater than or equal to 3+ at 20 years is 92%. So if you pick the right leaflets, you do the operation technically correct, the Valsalva graft is a very, very effective. Not all valve, you say leaflets, Tyrone will get mad. He always calls them cusps, so just so you know. This is an example of a Marfan patient with a cusp that's just simply not sparable. You want more normal cusps to repair. This is another example of a Marfan patient. These cusps just simply not something that would tolerate being put into a Dacron graft and have any sort of chance of holding up over a period of time. So let's go through just a quick case diaphragmatically. Patient with Marfan syndrome, root aneurysm. Actually, the cusps are pretty good. There's very little in the way of aortic regurgitation. Roots enlarged and actually probably been growing over time. So we take them to the operating room, place them on pump, take out the ascending aorta, and then remove the sinus segment, mobilizing the coronary arteries on buttons of aortic tissue. And we not infrequently use a second graft distally, as shown here. Approximately, I take 6 pledgets and place them in a subannular fashion, one below each of the 2 commissures and one at the nadir of each of the sinuses. We put those through the base of a graft, pull the graft down, pull the valve leaflets on up, and then resuspend the valve structure inside the graft in an anatomic position. And then we reattach the coronary arteries to openings in the graft, and then sew the 2 grafts back together. You end up that kind of reconstruction simply there. This is just a quick video showing that. This is removing the non-coronary artery sinus. And the really important thing here is careful mobilization of the coronary arteries. Really what you want to do is remove them going down along the sinus area. This is using the El-Curry technique from the commissure between the left and the non to get the size of the graft. Then we'll place these grafts that are subannular on the inside to the base of this graft, and then we'll settle it down, pull the valve structure up inside of it, and then resuspend it. The keys here is these commissures got to be pulled up tight, not so tight that they plicate the graft, but so that they're all the way up. You don't want these leaflets or cusps to be prolapsing. There's been some reports where that's all you do, resuspend them and you're done. But most of us go back in and do a running suture on the aortic tissue annular junction, and then we test the valve, and if it needs some tweaking, we'll do that. Here it looks very good. In this particular case, Marfan tissue, I decided to take some pericardium and create little support mechanisms for the coronary artery osteo. We don't do that so much anymore, but I think if it's really, really thin, it's not an unreasonable thing to do. And then we do the distal anastomosis and then reattach it to the graft that's used to replace the root, and then we'll reattach the right coronary artery at the very end. I use that smaller graft to kind of pull in the sinotubular junction a little bit. There's a Findel-David formula for sizing of these grafts, but quite frankly, what we end up doing is using a lot of 30s on men and 28s on women with some modification based on body size, and that's what that ends up looking like. And then the postoperative of echo here, it didn't have any leakage to begin with. It certainly shouldn't have any leakage at the end. Also, very importantly, you don't want those valve cusps to be prolapsing. I think it's also, Dr. David does about 8 Bentel operations for every valve sparing operation that he does, partly because with valve stenosis, you're not going to be saving the cusps. But anyway, it's very helpful to remember that a Bentel operation is still a very, very good operation. So this is a bicuspid valve. It can also be used for bicuspid valve. The fusion of the right and left cusps is the most common situation. In order to free up that leaflet, it's not uncommon to have to take the raphe between the two and trim it off a little bit. Hopefully that's what we're going to look at here. That's looking down on the bicuspid valve. You can see that the calcium in the raphe is pulling the leaflet up, so we'll take a 11 blade and trim that. It just frees up the leaflet here. It's been tried, if this leaflet is contracted, to put some bovine pericardium to extend it off of the annulus and leave the natural free edge. That actually has not turned out very, very good. And then occasionally we'll get a large leaflet, usually the non-coronary artery cusp, and it sometimes is overly redundant. And the support is thinnest up at the top of the commissure. So what we try to do is, if we have to shorten that leaflet, we'll do it by plicating the leaflet at its mid portion where it's got some tissue strength. So who's a candidate for this? Well, generally, of course, with an aneurysm, and it can be used in dissection, both tricuspid and bicuspid valve. Can't overemphasize, you have to have normal or near normal aortic valve cusps. We set up a registry years ago, multi-institutional. There were 19 sites worldwide. And it was a prospective observational registry. And what we were looking at was comparing valve sparing versus Bentel operations, specifically in Marfan patients. So the genetic core was actually Johns Hopkins, which vetted all these patients to be Marfan patients. And the imaging was at the Mayo Clinic, because most of this stuff is off echo. We thought it would be about 50-50 at the best, but it turns out it was 1 to 3 aortic valve replacement Bentel operations versus aortic valve sparing. And we looked at 10-year survival. Just go through just a little bit of this. Unadjusted survival out to 10 years, there wasn't any difference. And even when we adjusted, there was a statistical difference when it was unadjusted, but when we adjusted things with an IPW format, the Kaplan-Meier survival out to 10 years was not statistically significantly different, although it slightly favored aortic valve sparing. So a lot of these reports in the literature, it's a little different to compare, because they'll take 3 and 4 plus, and there's some reasons for that as aortic valvular regurgitation over time. But we actually took 2 plus, 3 plus, and 4 plus in this particular review, and using the adjusted competing risk model, the aortic valve regurgitation, as you might expect. I mean, these mostly are mechanical valves that we were comparing them against. There was a fair amount of valvular regurgitation over time. It was statistically significant. And most of that was based on structural degeneration over time. There was more bleeding with the mechanical valves, obviously, from the Coumadin situation. And for the MAVRE, you can see here when it's adjusted, there wasn't statistically different, but it actually was. When you get down to about 8 years, they essentially crossed. So we thought that was an interesting thing. So reintervention, you don't reoperate on 2+ in most people. So got to keep that in mind, and that's why the reintervention rate compared to the aortic valvular regurgitation and deterioration is a lot higher. Many of those people, and I'll show you here in a second, are going to get operated on with enough time going by. But out to 10 years, there really wasn't, with regards to reintervention, a difference between the two. But we've got data going out beyond 10 years in a lot of these patients now, and the reinterventions really are accumulating starting at 10 to 15 years. And so I will not be surprised that we get out to 15 years that the difference is going to be statistically significant, but we're going to have to see. I looked at 289 of my valve sparing operations. If you remember in the pairs operation, the average age is like about 33. If you look at Tyrone David's series, it's almost a decade younger than the ones that I've done the operation on. About half of them have had hereditary disease, and a quarter of them have actually had Marfan syndrome. Haven't done a lot of it in dissection, but we've certainly done some. Most of these are obviously done electively. I've done almost 70% of mine with an open distal anastomosis. You can see here hemiarch and a few full arches. If you look at Tyrone David's data, it's probably about 10% with hypothermic circulatory arrest. He makes every effort to just do a cross clamp without adding that bit going up into the proximal transverse aortic arch. This is just comparing the elective versus the emergencies, and of course the electives do much better. The operative mortality has been extremely low, and the paraplegia rate, as you might expect, has been 0, and the stroke rate has been very, very low. So what about this operation, as Dr. David really conceived it, was going to be most valuable in Marfan patients. So he uses the inclusion technique in virtually all Marfan patients. And he still, in older patients, will use the non-inclusion technique where he supports the annulus on the outside in older patients. One of the reasons his valve sparing in this particular approach is in a younger group of patients than what we see. Well, there's a famous paper that's people quote all the time, which there's 675 Marfan patients from a report from Hopkins by Vince Gott back from right before, in the New England Journal of Medicine, right before 2000. Most of these were mechanical composite valve grafts. They were young patients with root replacements. Dr. Cooley actually contributed some of these patients, and Reed Pirates, who was the geneticist at the time, who later went to Penn, was there at Hopkins at the time. He was sort of an understudy of Victor McCusick. So the elective repair, the risk was very, very low. In an emergency, the mortality rate as high as 12%. So let's look at a couple of meta-analysis of Marfan patients, looking at this valve sparing versus sort of Bentel operations. And this is one from 2011 from Benedito. And he looked at 11 retrospective studies with over 1,300 Marfan patients. And it was 900 plus valve replacements with Bentels and 413 valve sparings. They were all done going back as far as actually in the 60s up to around 2010. And what he found in a nutshell was that the endocarditis, there was no difference between the two. Reintervention, as we talked about earlier, was higher in valve sparing, and thromboembolism, of course, higher in the mechanical aortic valve prostheses. This is a little more recent meta-analysis, 23 studies, almost 3,000 patients, almost 50-50 with composite valve grafts versus valve sparing. The valve sparing has shorter follow-up. This is reported in the Annals of Cardiothoracic Surgery in 2017. And what he found was in valve sparing, there was a reduced risk of thromboembolism, late hemorrhagic complications, and endocarditis, no significant difference in reintervention rates. If you go back and remember what I showed you before, the follow-up was much shorter in the valve sparing and still under 10 years. And I think what we're really going to see in this, in Marfan patients, you get out past 10 years, the reintervention rate is going to jump up. But so in late mortality, it favored valve sparing as well as thromboembolic events, hemorrhagic events, of course, because of the Coumadin. Postoperative endocarditis, interestingly, favored valve sparing. And as I mentioned, reintervention, there really wasn't much of a difference between the two. This is a little more recent analysis, 33 studies, almost 1,800 sparing operations and over 2,200 basically Bentel operations. The early mortality was about the same between the two. Late mortality also, there was no statistically significant difference. And again, endocarditis favored sparing as well as thrombotic events. And then freedom from reintervention actually in this study, because the way the mix of the cases were, interestingly, in the studies that they included in the meta-analysis, that it was a longer time frame that they were following these patients in the series which were included, and so reintervention was beginning to accumulate in the valve sparing, and you can see here that from a reintervention standpoint, mechanical replacement was favored. So we talked about valves. The inclusion technique using a straight graft, which is what Tyrone David has really favored for his entire career. And when he talks about this operation, he emphasizes it very, very heavily. But he writes that as physiologically unsound as it may be, the clinical outcomes of reimplantation of the aortic valve into a tubular Dacron graft have been nothing short of outstanding when the operation is correctly performed in patients with normal or near normal aortic cusps. He also, in his writing, addresses the sinus and Valsalva grafts. Or it's possible that the change in geometry of the reconstructed root with a smaller aortic annulus in a larger sinotubular junction may provide a satisfactory condition for the aortic cusps to fulfill their function in spite of grossly abnormal flow assessed by four-dimensional cardiac magnetic resonant imaging. There's some MRI imaging studies that show that the laminar flow and all the root on MRI scanning in 4 dimensions is more disturbed in a sinus Valsalva graft than it is with a straight graft. So he's saying, well, even if it's all kind of abnormal, well, maybe you guys can get away with it, and it's probably not all that bad. However, I think he has ultimately has the last laugh, because he comes back, always talks about the surgeon's experience remains the most important facet of aortic root repair. I mentioned very early on that he took the straight graft in the very early years, and he's done this on and off, where he would take little pleats to create sinuses. Not quite like the sinus of Valsalva graft, but to mimic it, very similar to what Craig Miller has shown at Stanford. And sometimes it's referred to as the Stanford inclusion technique. But he states that he's absolutely convinced that his straight graft with and without his sinus plication, when those two things are compared out to over 30 years, he says it makes absolutely no difference in his hands with his selection process. So it's a safe and durable procedure. The main indication is aneurysm, generally without a lot of severe aortic regurgitation. You have to have normal or near normal cusps. It has the advantage of avoiding lifelong anticoagulation. But the technical details of this operation is compared to a Bentall operation extremely important. And you have to leave the operation without prolapse and without regurgitation. Craig Miller describes this operation. He said, with a Bentall operation, there's several things that can go wrong. In a valve sparing operations, there's dozens of things can go wrong. That's some insight into the need for technical precision when you're doing this operation. Just want to remind everybody that the Aortic Symposium is not going to be this year, but it's going to be next year. This is the AATS Aortic Symposium. It's going to stay in New York, but it'll be about this time in 1 year. If you want to know anything about the aorta from the valve to the bifurcation of the abdominal aorta, it's a great meeting to attend, and we look forward to seeing some of you all there. Thank you for your attention this afternoon.